Hello, my name's Julian and I am an emergency medicine trainee doctor working in the UK, and today is another attempt at me updating an area that I feel I need to improve, which is recognition of acute coronary syndrome. I find that trying to teach something after I've been looking into it helps me a lot and hopefully helps other people as well. So thank you for joining me on this ride. So we're talking about recognizing ACS today, and this is not so much a technical talk, but more of a looking at our current paradigm and trying to make a bit of a paradigm shift to recalibrate our lens of how we interpret findings for ACS. So what are we talking about specifically? Well, we're going to be looking at why framing myocardial infarction as NSTEMI and STEMI is actually damaging for patients. We're going to look at why we've set the goalposts wrong in this regard and try to reconceptualize a new, well maybe not so new, paradigm shift in looking at how we recognize acute coronary syndrome. And it's just worth saying that none of this is of my own discovery. Obviously, I'm standing on the shoulders of a lot of different people, particularly these fellows here who've written the OMI, or the Occlusive Myocardial Infarction Manifesto, Dr. Pendle Myers, Scott Weingart and Stephen Smith. So I really recommend you go and check out that stuff, because a lot of what I'm talking about, pretty much everything is in there. Okay, so let's go back to medical school. How have we been taught to conceptualize myocardial infarction? Well, this is something that might be very familiar to us, but we have, bifurcating from the umbrella term of acute coronary syndrome, the two entities of non-ST elevation MI and ST elevation MI. And with those presentations that seem to be ischemic in nature without ST elevation, the troponin result differentiates those into either unstable angina or a non-ST elevation MI. If you've got a normal troponins, you tend to be able to classify people as an unstable angina, but of course with increasingly sensitive troponin assays, that group of people is getting smaller and smaller, and those in the NSTEMI group are getting proportionately larger. So on the other hand, in acute coronary syndrome, as we know, it's a spectrum. Going over to the further end, we've got ST elevation MI, or STEMI. And I'm not trying to teach you to suck eggs here, but just to reiterate, we've got this difference in ST elevation MI and non-ST elevation MI. This is what we've been taught anyhow. So ST elevation, we are looking at the J point, which is the transition from the QRS to the ST segment, and if we're seeing elevation of this J point that meets certain criteria, we can call something a STEMI in the context of a clinical presentation of MI. NSTEMI is anything other than that, essentially, which has evidence of ischemia or infarction either on troponins or coronary angiogram or echocardiogram. So that could be ST depression on an ECG, T-wave inversion, could be different morphologies that are just generally indicative of ischemia. All right, so what have we been taught specifically about ACS in this regard? We've been taught to look for STEMIs. And the reason for that is because the ST elevation MI, as we've been taught, is on the furthest end of the spectrum that indicates complete infarction. It's worth just mentioning, what the heck do we mean by a STEMI? Well, the fourth universal definition of myocardial infarction, which is broadly used universally and globally, is as follows. You can basically read it there. I'm not going to read that all out, but there are specific criteria measured in millimeters, depending on the age of the patient, depending on whether it's the precordial leads or the limb leads. And this is what we tend to fall back on to say, is this a STEMI or not a STEMI? And in fact, those measurements have been deduced by discriminating ST elevation, which is positive for creatinine kinase, from ST elevation that is not positive for creatinine kinase. So it's not even derived from angiographic studies that actually prove that there's occlusion going on. It's just purely from an older type of biochemical marker, creatinine kinase, and trying to differentiate, oh, by the way, these people who had ST elevation and a high level of CK had these sorts of measurements in their ST elevation. That's how these definitions have come about. So we've been taught to look for STEMIs. And why has the word STEMI been burned into us since medical school? Well, we've been taught that STEMI indicates total occlusion of a coronary artery and requires emergence, less than 2 hours, PCI or Cath lab. The reason for that is because if left untreated, you get complete infarction, necrosis, suboptimal remodeling of cardiac tissue, obviously death, morbidity, a whole host of really bad outcomes. And so we've been taught to diagnose total coronary occlusion by looking out for ST elevation and STEMIs on ECGs. That's really the thing that we've been taught to look for. Anything other than that is an NSTEMI. So let's have a look at a couple of ECGs and deduce, is this a STEMI or not? So we're not going to go through a very, rate, rhythm, all those different steps of looking at the ECG. We're just going to do a quick eyeball. And I think you'd be right to say that you've got these pretty huge looking ST elevation segments going on all the way through the vast majority of the precordial leads, and even in some of the limb leads such as 1 and 2. And in the context of chest pain, you might be forgiven thinking this is a ST elevation MI. It's certainly more than 2 millimeters above the isoelectric baseline, so it's meeting criteria according to that definition we looked at previously. However, this is actually benign early repolarization, a normal variant of ECGs that's found very commonly, particularly in younger people, for example, and it's a type of ST elevation, but it does not indicate coronary occlusion, ischemia, or infarction. And this is a false positive. And there are many false positives that end up going to Cath lab, ultimately ending in a patient getting just pure harm because they've got no indication for angiography. Other things that can lead to false positives are left ventricular hypertrophy, pericarditis, left bundle branch block, pacemaker rhythms, the list goes on. But there are false positive ST elevation morphologies that can lead you down the wrong path. And so that's one thing that we need to bear in mind for STEMI paradigms. So how about this one? Well, if we open this up, let's have a look again. Looking just a broad brush approach. Again, like I said, it's not a technical talk here, but we're just doing a broad brush. Precordial leads all look pretty good. Can't see any obvious ST elevation. Let's imagine this person does have chest pain. AVR all looks fine, AVL looks fine. 1, can't see any ST elevation. We get down to the inferior leads and there's maybe something going on. It's difficult to say. Lead number 2, if we look over here, there's not really 1 millimeter of elevation there. Again, lead 3, not really 1 millimeter either, maybe half a millimeter. AVF, similarly, maybe half a millimeter of elevation. So actually, this isn't fitting criteria for ST elevation MI. So this would by definition be an NSTEMI if we had, for example, positive troponin come back. But if we look at the outcome of this actual patient who had this ECG recording, they did go to the Cath lab. And unfortunately, or fortunately for them that they went to the Cath lab, they were found to have 99% circumflex and 95% right coronary artery occlusion, which is pretty much total coronary occlusion, which is what we've been trying to look for. But in this case, the STEMI criteria has let us down, and it's not found it. So this person wouldn't have had the Cath lab activated for such an ECG. So we might be suffering from the wrong goalpost syndrome. Instead of thinking, is this a STEMI? We should be thinking, is this total or acute coronary occlusion? Because as we've seen, you can get false positives and false negatives with a STEMI. Although it's been an interesting point that's been made from the viewpoint of false negatives, because by definition, you can't have a false negative STEMI. It's either ST elevation or it's not. So if this person does not have a STEMI, it's not a false negative, because by definition there's no ST elevation, even though that they have almost total coronary occlusion. So we're kind of blinkered into this binary approach to looking at acute coronary syndromes from the NSTEMI and STEMI paradigm. And moreover, anything else other than ST elevation MI that meets those strict criteria that we've seen is automatically labelled as an NSTEMI. And so really the STEMI-NSTEMI paradigm has failed us, I think, and certainly a lot of people do think so too. So as we move on, let's just have another look at a couple of other ECGs. So thinking again back to, we're looking out for total coronary occlusion, and we're going to layer on our STEMI-NSTEMI paradigm to try and identify this. Can we see any ST elevation anywhere? Well, not really is the answer. Can we see anything going on? Well, I suppose if you're maybe looking quite astutely, you might notice that there's these fairly large looking T waves. They're not massive. However, in the context of their adjacent QRS complex, they are ginormous. You should never be able to fit a QRS within a T wave. That's completely abnormal. For this person specifically, if we look at, I believe it's this one. Yep, here, same ECG. Unfortunately for this patient, they were discharged with diclofenac, and 12 hours later they were found collapsed at home with no signs of life. And actually, this ECG, with its hyperacute T waves, is diagnostic of left anterior descending artery occlusion, even though it didn't fit STEMI criteria. This person should have been at the Cath lab. These are De Winter's T waves, or hyperacute T waves. Let's have a look at another ECG. So again, we're looking for that, ST elevation. Is there coronary occlusion going on? Have a look at the precordial leads. Can't really see. I mean, someone might think, oh, there's a bit of ST elevation there, but actually with an S wave in V3 and V2, that's just benign early repolarization going on. So there's no ST elevation that's worrying around there. How about around here? 2 looks okay, maybe 3, there's a little bit, perhaps a millimeter. AVF, just about perhaps a millimeter, but really some people might argue against that. It's difficult to say. If we move on to, I think it's here, yes, we can see that actually this was an inferior MI that was missed, with an 80% right coronary artery occlusion. But strictly speaking, this may not have met the STEMI criteria for which we are taught to implement. So let's just bring this all back to what the hell is our primary concern with all of this. When we're seeing a patient and they're coming with chest pain, we're worried about ischemic chest pain, what is our primary concern? Our primary concern is coronary occlusion that results in myocardial damage and loss. That's what we need to think about. It's not about, is this a STEMI? Because the ST elevation might be a false positive, or it might not even be there, despite there being coronary occlusion. So how do we stop this coronary occlusion happening in our patients? Well, we need to be able to identify 2 kind of broad groups. The first one is those with ongoing or imminent, impending, irreversible myocardial damage who need emergent reperfusion. Those STEMIs that you're thinking about would fit into this group if they are genuinely having coronary occlusion. But as we've seen, there's also a large group or cohort of people who do not have ST elevation who are also in this group. So that's the first group to identify, because they need emergent intervention and time is muscle, and so they need to get sorted ASAP. The second group are those who need urgent treatment. So this might be people who need angiography, within 24 hours, 72 hours. They might need medical management like dual antiplatelet therapy, anticoagulation, but they don't need emergent transfer to a cath lab. we've got these two groups going on. And so just a really brief revisit, what actually occurs when you're having a type 1 MI? Well, this is a pretty rudimentary picture, but basically just goes on to illustrate that we have atherosclerosis that builds up over a period of time, lipid deposits, LDLs, that deposit into the arterial intimas, and you get build-up of pro-inflammatory molecules, cytokines, neutrophils, etc. And eventually you can get like a plug that builds up with all of these different constituents, and if you get a rupture of that plaque or erosion of that plaque, it becomes prothrombotic, platelets can aggregate, clotting cascades go haywire, and eventually you can end up with a complete occlusion of an artery. And that's a pretty inferior view of the heart. If we look here, that's probably the kind of orientation we see a heart if we look at somebody dead on from the front. So just to remind ourselves of the coronary vascular supply, we've got the ascending aorta from here, and we've got the right coronary artery branching off from the aorta, which in about 80 to 90% of people goes on to supply the posterior descending artery as well, which supplies the base, the posterior part of the heart down here, of the ventricles down there. So that's the right coronary artery, supplies the right ventricle, parts of the right atrium as well, and then behind the pulmonary artery here we've got the left coronary artery, and that bifurcates into the left anterior descending, the LAD, and the left circumflex, which comes around here. And in the remaining sort of 10 to 20% of the population, the posterior descending artery is derived from that left circumflex. Okay, so those are the arteries that we're primarily concerning ourselves with. So when you get an occlusion of an artery, we already know that those arteries are on the outside of the myocardium, of the heart muscle. And so if you get an occlusion here, the first bit to suffer is that most distally to the artery down here, around the endocardium. And as time goes on, that ischemia and infarct starts to spread more proximally towards the artery. And if you get a full through and through infarction, that's a transmural infarction, and what we want to avoid, and why we have pathways for emergent PCI in place. Okay, so as we go on, we're just going to be doing ECGs here and there just to hammer these points home. So again, let's see if our STEMI, NSTEMI paradigm helps this patient here. So we're looking around, can we see anything that might be worrying in the context of chest pain? Well, we do have some ST depression going on over here, I suppose. And actually, it is at least 1 millimeter, certainly 2 millimeters over here, and it's in contiguous leads. Now we know that NSTEMIs, you can't localize territories with ST depression from an NSTEMI, but nonetheless, let's just say that we do have some ST depression going on around here. So let's say we get a troponin back and it's raised. We might admit this person for medical management of a non-ST elevation myocardial infarction. Would this have been the right decision? Well, actually, what you've been looking at there is an isolated posterior MI, which if you had done your posterior leads, i.e. leads V7 to V9, you would find that actually this is ST elevation. It's only ST depression because it's reciprocal. But if you put the leads in the right place, i.e. on that person's back, then you'll see that this is actually an ST elevation MI. And this particular person with this particular ECG was found to have 100% proximal circumflex occlusion. And that, just to remind you, proximal circumflex would be the artery coming down here, and they would have been in that 10 to 20% of patients of the population who have a posterior descending artery from the left circumflex, the left side, instead of the right side. How about this one? So again, ST elevation, non-ST elevation, let's have a look, see what we can find. Well, just glancing around, I can't really see any obvious ST elevation except maybe in this lead over here, V2. So let's take our J point to be something like here. Well, that's certainly at least 1.5 millimeters high. Might not hit our criteria for ST elevation, considering it often has to be 2 or more millimeters, but let's just give it the benefit of the doubt and say that it is meeting that. Well, if we go down here, remember we need 2 contiguous leads, and actually this doesn't really have ST elevation meeting that criteria, nor does the one above it. So actually we've got this isolated, strange looking biphasic ST segment, likewise with V3, but in the absence of ST elevation meeting specific criteria, we're not going to be able to call this a STEMI. So let's say that the troponin comes back and it might be a bit normal, or it might be slightly raised, and this person might be lucky enough to get admitted for observation, maybe some medical management. Would that have been the right decision to make? Well, this is Wellens syndrome, or Wellens sign. And this is a specific sign that occurs in leads, I think it's V2 to V3, when somebody has a spontaneous reperfusion of the left anterior descending artery. So this is the kind of ECG that you'll see when the patient is pain-free, but it actually indicates that there is stenosis, critical stenosis of the left anterior descending artery. It just so happens that they've had and been lucky enough to have a spontaneous reperfusion of that artery at the time, but they're at extremely high risk for total transmural infarction. And so when this person went to the Cath lab, they were found to have a 95% stenotic LAD. So these people don't meet STEMI criteria, but they would highly benefit from going to have PCI. So once again, we need to just really get in our head, what do we care about here? We care about coronary occlusion, whether it's ongoing or whether there's a patient that's at high risk, so that we can identify them. We do not care, and it should be becoming more apparent that we do not and should not care about, is this a STEMI versus an NSTEMI? We want to know, is this coronary occlusion or is it not coronary occlusion? STEMI is a proxy measure which can be misleading and can be very poorly sensitive, that will cause us to miss coronary occlusion when it's actually present, as already evidenced by these ECGs that I've shown you. Okay, so how do we actually diagnose coronary occlusion then, just kind of taking a step back? Well, the definitive way is coronary angiography. That is the definitive way, but of course we can't just put every single patient who comes into the ED into the Cath lab, because 50% of those, up to 50% of those, will have pretty much no obvious etiology for their chest pain. So there's other modalities that we have to fall back on. History and exam, that's the first thing we have to do, most basic thing, and you have to do this. But we already know that up to 30% of people with myocardial infarction actually have no chest pain, which is terrifying. They might have sweating, nausea, might have, might be burping or have a lot of wind. They might be short of breath or a bit clammy, lightheaded. They don't necessarily have to come in with chest pain. And with of those who have symptoms suggestive of ACS presenting to the ED, only 10 to 15% are actually having an MI. So the 85% who are not, they look exactly the same in many instances. And so they need similar diagnostic testing to rule this out or rule it in. And 2% of those patients who are discharged from A&E are actually experiencing ACS. And it's important to note that with increasing age comes decreasing sensitivity in detecting ACS from symptoms or examination. Many elderly people do not have any feeling of pain when they're having acute coronary syndrome, and they can have odd things like some epigastric discomfort or lightheadedness or just fatigue even. So history and examination is very, very tricky. So how about troponins? Well, actually, they may be negative in ACS. So the first thing to say is unstable angina. You will not have a rise in troponin in unstable angina. That is based on your risk factors, the history and exam that you're taking, and your general gestalt and plugging them into a GRACE or a heart score, for example, but they're not going to have a rise in their troponin. They're still going to be treated under the current paradigm in the same way as an NSTEMI though. So that just goes to show how high risk they can be. Furthermore, as we've seen, Wellens syndrome, LAD critical stenosis, many times have a normal troponin or close to normal, like a borderline troponin, even though they can have a 95% stenotic LAD, for example. So troponin is one of the best things that we have, but it's not 100% sensitive in capturing very, very, very high risk patients for complete or acute coronary occlusion. So how about echo? Well, we can use that, and people do use that with POCUS, point of care ultrasound, to try and detect wall motion abnormalities, but it requires expertise and training, and you can only have one echo machine, generally speaking, per patient, whereas maybe troponins are easier to take, and it doesn't need the same degree of expertise. So it's quite a high barrier to entry to start to utilize this in a really meaningful way in your department. And also, there can be many other causes of abnormal wall motion in people who are coming in. It doesn't have to be because they're having acute myocardial infarction. So ECGs, that's what we're going to settle on with, increasing our sensitivity to finding people who are at risk or having acute coronary occlusion, which, remember, is our primary concern here. So ECGs, they're near immediate, they're non-invasive. You can have serial ECGs to find dynamic changes, which are pretty much a smoking gun in the context of chest pain and symptoms of acute coronary syndrome to diagnose such a thing. They can show acute coronary syndrome when bloods and clinical picture don't. And I guess one of the things to say is, as a caveat, that less than 50% of people with ACS will actually have a diagnostic ECG. And up to 30% of those with, for example, NSTEMI or ACS might have a normal ECG. It's operator and interpreter dependent, and that's why the onus is really on us to get as slick as we possibly can at interpreting ECGs. Again, reminder, what is our primary aim? It's not to say, is this a STEMI or an NSTEMI? We're not interested in that. We're interested in identifying who needs emergent angiography and identifying who needs urgent treatment and accurate risk stratification. It's not STEMI versus NSTEMI anymore. So how do we currently decide who needs emergent less than 2 hour angiography? Well, as I've said, if there's a STEMI, it's pretty much it. There are some other indications from an NSTEMI perspective, which I think a lot of the time get sort of drowned out by the constant idea that STEMI is the real thing that activates a cath lab. So these are some other indications from the European Cardiology Society: hemodynamic instability, cardiogenic shock, recurrent or refractory chest pain despite medical treatment, life-threatening arrhythmias, mechanical complications of MI, acute heart failure clearly related to non-ST elevation MI, and then ST segment depression, basically different types of ST depression and ischemia, which could be a proximal left coronary artery occlusion, which is what this is sort of referring to, or multivessel disease. But these are indications that might not be most forefront in our minds, and I would argue that that is because the term itself, being as catchy as it is, STEMI, can often drown out our awareness of these being other indications for immediate invasive angiography. So STEMI is somewhat problematic. So where did... Oh, here we go. We got another ECG. So let's have a look, because we're just trying to hammer this home, aren't we? So we've got this other ECG to look at. Again, NSTEMI, STEMI paradigm. Can we identify whether there is something bad going on? Let's have a look at our precordial leads to begin with. Well, we've got that kind of weird biphasic T wave going on here, but it's the wrong way round for a Wellens. The rest of the leads look okay. How about over here? Well, we've already been caught out by 1 or 2 inferior infarcts, so let's just have a look there. 2 looks okay, 3 looks okay, AVF looks okay. Got a bit of T-wave inversion in AVL, but really there's no convincing ST elevation going on. Well, how about if I said that, again, in the context of this QRS complex being the size that it is, how massive does that T-wave look now? So that is another hyperacute T-wave that we've got going on there, and somewhat there as well. So we've got hyperacute T-waves with reciprocal ST depression in AVL. This is actually an inferior infarct that's going on. Let's just see if we can find... Here we go. So this is the ECG, and it's from Life in the Fast Lane. And if we look down here, hyperacute T-waves in the inferior leads concerning for early inferior occlusive myocardial infarction, demonstrated best by their size relative to the preceding QRS complex. And that degree of relativity is something that the current STEMI definition and criteria does not allow for. We'll come on to that later. So where did this whole STEMI and STEMI thing come from? So it's worth just going a little bit over the evolution of MI management, because it's pretty interesting, to be honest. This is a prescription from 1955 for managing coronary occlusion. Basically, put the patient at ease, make them as comfortable as possible, absolute bed rest is essential, oxygens should be started immediately, give them some morphine, give them some external heat, give them some caffeine, avoid adrenaline nitrites and digitalis, and basically just keep them in bed for 6 weeks. That's what we had. And so in the pre-reperfusion era, we had Q-wave and non-Q-wave MI. And what would happen is people would come in with symptoms highly suggestive of acute coronary occlusion, and they'd just have to sit there while they infarcted. And after the event, you could see, is this a Q-wave MI or a non-Q-wave MI? And the thinking was, if it's a Q-wave MI, you've got transmural, full thickness infarction, and you could only wait around and see if that was the case. But in fact, autopsies later on shows that there was slightly less, what would you call it, relationship between Q waves and full transmural infarction. So that was about as good as we got back in the day. So the reperfusion era from 1980s to the 1990s onwards, when streptokinase was discovered. And this particular study, the Fibrinolytic Therapy Trialists meta-analysis, pooled 58,500 patients who were enrolled in 9 RCTs across the 1980s. And this is where we got our STEMI, NSTEMI paradigm from. And since the 1994, it has persisted all the way until now. It's not been usurped by any other studies. And we're going to have a look at actually what the heck went on here. So this study, this meta-analysis looked at studies that randomized high-risk patients with clinically concerning chest pain, plus or minus concerning but undefined ECG findings. So some of the studies did take into account the ECG findings. Some of them just randomized them based on clinically concerning chest pain. And those patients in these groups were either randomized to thrombolytics or placebo. So they didn't get any angiography or anything. They were just given the thrombolytics based on the chest pain or the clinical picture, plus or minus these ECG findings that were undefined. So there was a retrospective analysis that after all of this happened, with the meta-analysis, classified the ECG into 3 different groups. STEMI with the ST elevation, but again, ST elevation was variably defined across all of these different studies. NSTEMI, obviously non-ST elevation, and then normal ECG. Those are the 3 groups we were dealing with. And the number needed to treat for all comers, didn't matter if they had ST elevation or not, was 56. So 56 people were thrombolized to save 1 life. And the researchers found that for those who were classified as STEMI, so had ST elevation, that number needed to treat decreased. So you only had to thrombolize 42 people to save a life. So that to them meant that, oh, STEMI or ST elevation must mean that there is more indication for thrombolysis. There is more chance of complete coronary occlusion going on. And the other thing to say is that there was a non-significant trend to harm for NSTEMI and normal ECGs, which is why NSTEMIs did not go down the path of getting emergent PCI. And so this NSTEMI and STEMI criteria is what we've ended up with. And it's given us this limited sensitivity and specificity because we've got these false positive patients who have unnecessarily received thrombolytics and false negatives in the NSTEMI group who didn't receive thrombolytics but had acute coronary occlusion. And indeed, this is what our current practice is really based on. So if we look at NICE guidelines, they split ACS into STEMI and NSTEMI. So for STEMI, it's reperfusion therapy, primary PCI or fibrinolysis, which is indicated for ST elevation MI. How about non-ST elevation MI, so those who aren't meeting criteria? Well, there's not a huge amount in terms of PCI, apart from if their clinical condition is unstable. Otherwise, consider angiography within 72 hours. But apart from that, we're going to give them medical management. So we've already seen that we've got a number of ECGs and patients who have presented without ST elevation, who have had 100% coronary occlusion in a number of different arterial territories, but under our current paradigm, they would not be indicated for reperfusion therapy. And again, the European Society of Cardiology has a similar definition, two groups of MI, ST elevation MI or non-ST elevation MI. I won't go into that bit, but that's just to say that we are still stuck on this paradigm, essentially. And just to further evidence this point, there's been literally tons of studies out there now, but I just picked a couple of the ones that are quite interesting and pretty big. So this was in the European Heart Journal, and it looked at non-ST elevation myocardial infarction. And basically, all of those who were diagnosed as NSTEMI who went on to have angiography. And of those who were diagnosed as NSTEMI who had angiography, 25.5% of them were found to have totally occluded infarct arteries on their angiography. That's 1/4 of NSTEMI patients out of 40,000 patients who were categorized as NSTEMI had a totally occluded coronary artery on angiography. So again, I ask you, is the STEMI and STEMI paradigm sensitive enough for us? And another study here where 3,000 patients were basically seen in, I can't remember where it was a different hospital elsewhere, but essentially 3,000 patients, each classified as STEMI, NSTEMI and control, 1,000 patients per group. The control group were just those who had no ACS on troponins, and it was all ruled out just to have a control there. And then NSTEMI would have had, you know, maybe some ST depression, etc., and positive troponins, and then STEMI is as you would expect. And they had expert cardiologists re-review the ECGs of the NSTEMI patients, and 28.2% of those NSTEMI patients whose ECGs were reviewed were then, by those cardiologists, reclassified as acute coronary occlusion. And they had some findings that went along with that. So we've seen hyperacute T waves, De Winter patterns, subtle anterior ST segment elevation, perhaps not meeting the criteria that we've been taught, non-consecutive ST segment elevation, so perhaps not in contiguous leads, and a whole host of other different areas. And it wasn't to say that 28% of the NSTEMIs were actually proven to have acute coronary occlusion, but of those who were initially thought to be NSTEMIs and recategorized as acute coronary occlusion, i.e. that 28%, 60% of those were found on angiography to have total coronary occlusion. So 60% of that 28% would have just been treated as an NSTEMI. So there's a lot of patients who are missed out. So this is a failed paradigm. The problems that we've covered, it forces a binary black and white thinking where it's either an NSTEMI or it's a STEMI. We know that medicine is way more complicated than that, and just having very specific criteria, I can't think of many other areas of medicine where if you don't meet a very specific threshold, then the entire diagnosis is immediately ruled out. There needs to be more of a appreciation that things are relative. So a small QRS with a relatively larger T wave is a hyperacute T wave. So we set the goalposts wrong. And as I mentioned, absolute versus relative measures. You can have absolute criteria for ST elevation, but actually the thing that matters is the relative amount of ST elevation. Potentially downplays other emergent causes for PCI that we've already covered elsewhere for NSTEMIs. False positives. Certain studies, for example, have shown that out of more than almost 1,500 patients with query NSTEMI, 14% had no culprit artery. And I know you can get MINOCA or MI without any occlusive artery, but all the same, there's a high problem in certain areas of practice of false positives going for angiography. And the main thing is it misses total coronary occlusion. So what's the alternative? Well, I guess there's a new paradigm really, which is the occlusion myocardial infarction versus non-occlusion myocardial infarction manifesto. And this is what I'd really recommend if you're interested in more of this to go away and read. It's a long but very, very helpful document that starts to delineate a bit more about the types of things that we should be thinking about with patients who are coming in with potential occlusive coronary syndrome. So this is the new paradigm that's been suggested. Acute coronary syndrome, history and presenting complaint, ECG, ultrasound. If findings are suspicious for OMI, occlusive myocardial infarction, then that would be indicative for emergent angiography. That box there replaces ST elevation criteria, and it frees us up to have a much more open mind for new findings to emerge in the field, for posterior MI, for different types of T waves, for many, many different things that indicate occlusive MI. It opens up that box to allow those patients who need emergent PCI to actually receive it. And that's what we need to be thinking about. Thank you very much for listening.